for the initial management of an enterocutaneous fistula, ECF. It is a systematic approach designed to stabilize the patient before any definitive surgical intervention is considered. In the exam, remember that patience is a virtue in ECF. Surgery is rarely the first step. The SNAP protocol. Letter. Component. Key actions and goals. S. Sepsis and skin. Sepsis. Identify and drain abscesses, CT guided. Start antibiotics. Skin. Protect the skin from corrosive enteric enzymes, zinc oxide, ostomy bags, or vacuum-assisted closure. N. Nutrition. Most ECF patients are malnourished. Start TPN, total parenteral nutrition, to allow bowel rest, or distal enteral feeding, fistuloclysis if possible. Aim for positive nitrogen balance. A. Anatomy. Anatomy. Fistula using imaging, fistulogram, CT with oral contrast. Ask, where does it start? Where does it end? Is there distal obstruction? P. Plan. Decide on the long-term strategy. Spontaneous closure usually happens within 5 to 6 weeks if the patient is stable and nutrition is optimized. 1. S. Sepsis and skin care. Sepsis. This is the number one cause of death in ECF. You must control the source. If the patient is tachycardic or febrile, look for a hidden collection. Skin. Enteric output, especially from high-output proximal fistulas, contains activated pancreatic enzymes that digest the skin. Specialized nursing and stoma therapy are vital. 2. N. Nutrition. High-output fistulas greater than 500 milliliters per day lead to massive protein and electrolyte loss. Goal. 1.5 to 2.5 grams per kilogram of protein and 25 to 35 kilogram of energy. The bowel rest myth. While TPN is common, if there is enough small bowel length, at least 40 to 50 centimeters before the fistula, enteral nutrition might still be attempted. 3. A. Anatomy, the investigation phase. You cannot form a plan without knowing the geography of the fistula. Fistulogram. Contrast is injected into the external opening. CT enterography helps identify associated abscesses or distal bowel obstruction. Friend mnemonic. These factors prevent spontaneous closure. F. Foreign body. R. Radiation. I. Infection/IBD. E. Epithelialization. Tract is too short, less than 2 centimeters. N. Neoplasia. Cancer. D. Distal obstruction. The most common surgical reason for failure to close. 4. P. The plan, surgical timing. Wait. Spontaneous closure occurs in about 30 to 40% of cases. Surgery. If it doesn't close, definitive surgery, resection and anastomosis is usually delayed for 3 to 6 months. Why wait? To allow the obliterative peritonitis, dense adhesions, to soften, making the surgery safer and reducing the risk of creating new fistulas, iatrogenic injury. High-yield one-liners. High-output fistula, greater than 500 milliliters in 24 hours. Usually proximal duodenum jejunum. Low-output fistula, less than 200 milliliters in 24 hours. Usually distal ileum colon. Octreotide, a somatostatin analog often used to reduce fistula output, though it doesn't necessarily increase the rate of spontaneous closure.